Good morning, and I want to thank the HFSA for inviting me to this illustrious panel. My assignment is to discuss how to approach percutaneous MCS for shock patients on the transplant list in the new allocation system. These are my disclosures. What is our objective when we plant an MCS in a patient on the waiting list? First and foremost, we want to recover the patient from a shock state. Second, we want to optimize the patient for transplantation. A preferred device should have a low insertion profile, high output, be hemocompatible, and have minimal interference with the transplant operation. Let me refresh you on the new allocation system. Status 1. Device is VA ECMO or non-dischargeable surgically implanted BiVADs. Status 2, MCS would be IABP Impeller or non-dischargeable surgical BiVADs. Status 3, LVAD complications and or 30 days discretionary time for durable LVAD. And status 4, just a durable LVAD without complications. How are the devices categorized for the allocation? HeartMate 2, 3, HVAD, and Jarvik are durable. The percutaneous devices are IABP, Impeller, and Tandem Heart. And the non-dischargeable surgically implanted devices, CenturyMark, ECMO devices, and Thoratec PVAD, as well as total artificial heart, which is dischargeable actually. When we choose the device, several considerations. First, insertion profile. IABP with the smallest insertion profile, 7 to 9 French. Impeller a little bigger, Tandem Heart and ECMO much bigger cannula. Ease of insertion, easiest with the balloon pump. Cardiac output increase. Clearly, Tandem Heart and ECMO will give us the most cardiac output. I'm going to say, despite this table here, that balloon pump and Impeller 2.5 may be quite similar. Implantation time, again, shortest for the balloon pump and longest for the Tandem Heart. Hemolysis is an increasingly recognized complication of temporary mechanical support. Very important in my opinion. IABP does not give hemolysis. Impeller devices, depending on positioning, may give quite a bit. With good positioning, maybe somewhat less. And then, of course, bigger impeller devices with less hemolysis. ECMO and Tandem Heart, somewhere in between. The bleeding risk, again, the least with the intra-aortic balloon pump, the highest probably with ECMO. Evidence of efficacy, let's take a look at that. But before we do that, let's first decide what kind of device do you actually need. Do you need cardiopulmonary support? In this case, you will need ECMO. Do you need just left-sided, just right-sided support, or just pulmonary support? This will drive what kind of MCS you will use. What are the routes of engagement in the new allocation system? VA ECMO is good for 7 days in status 1. Certain blood pressure, cardiac index, and wedge criteria have to be met before you implant it. And then after 7 days, you must either transition to a durable device or demonstrate a contraindication and or demonstrate failure to wean by reaching certain hemodynamics as shown here with a low blood pressure and a low index. Surgically implanted BiVADs, 14 days, no hemodynamic or weaning criteria. Status 2, probably the most important one, IABP Impeller, 14 days. Again, you need to meet similar hemodynamic criteria for insertion of these devices. And again, after a 14-day period, you must justify extension of support either by contraindication to a durable device or by meeting and or by failing to successfully wean the device. Hemodynamic criteria, again, low blood pressure, low index, high wedge. Surgically implanted LVADs or AVADs, no hemodynamic or weaning criteria. Status 3, if you have not justified renewal of the status 1 for ECMO or 2 for IABP Impeller, you will drop to status 3. Now, let's take a look at the real world, and I want to draw your attention to the real world right here, which are ICUs that are not in transplant centers. And these ICUs have not at all been affected by our allocation system change. In contrast, when you look at US transplant centers ICU, a very significant shift from a 25% to 42% use of temporary mechanical support in shock cases. So big difference whether or not you're a transplant center, in whether or not you feel MCS is needed. This is, of course, of interest. This paper, again, very nicely shows a fairly dramatic increase of balloon pump use in patients who are actually transplanted before the new allocation, around 9%. After the new allocation, almost 30% of transplants occur off balloon pump. Why is that? One of the reasons, certainly, that the wait time at about 22 days is quite short in the new allocation system as compared to almost 2 months in the old allocation system. How is it that the balloon pump is suddenly used so much when we know that it does not work in the SHOCK 2 study, in the STEMI study? Now, importantly, when we talk about the balloon pump, let's also talk about the Impeller 2.5. In multiple smaller studies comparing these two devices, really no outcome difference, maybe a small difference favoring the Impeller for more hemodynamic support. So neither of these pumps should really work in severe shock according to these criteria, but it is important that that experience was in STEMI, the SHOCK 2 study. We're dealing with acutely compensated chronic heart failure usually, and that's a very different physiology, as shown here very nicely by my two panel colleagues, Justin Fried and Rishad Guran. When you place a balloon pump in such a patient, a decompensated heart failure patient, you get a highly variable response in cardiac output with a significant number of so-called super responders that actually have a cardiac index increase of more than 1 liter with a balloon pump. Certain criteria can identify poor and good responders, although I will say, as much as I love this paper, and I really do, more work is needed here to fine-tune this approach. So how do we approach the patient on the wait list who is in shock? First of all, very quickly, I only have 7 minutes here to do this, so I will end shortly. Determine the need for mechanical support. Do they need it? Do they need biventricular support and or pulmonary support? If they need left-sided support only, place an IABP as first line. Consider an axillary placement. Assess the hemodynamic response by just looking at the augmentation. You can also check the cardiac output, FIC output. And if the support is inadequate, and only then, consider an upgrade to an Impeller 3.5 and or, if even more support is needed, an Impeller 5 or an ECMO, of course, which have to be inserted by surgeons or also by cardiologists, but it is much more involved. I want to leave you with a word of caution about the axillary balloon pump, particularly in the setting where you upgrade a patient who fails the balloon pump to ECMO, peripheral ECMO. You now push the balloon pump back into the arch as shown here. And actually, we had a case where the balloon pump went all the way into the left ventricle. And you can see this here actually, quote unquote, very nicely by the position of the proximal and distal marker of the balloon pump. And we recently published this if you would like to look at it. But I have to stop here. My time is up. So I want to again say thank you to the organizers and hope for a good discussion after these talks.